I'm just getting started, so we're in chapter 16,
Okay.
Basics of Health Insurance. And we'll be doing that one and going into the medical billing and reimbursement, chapter 17 as well.
Okay. Did the school tell you that I was on vacation? That's why I wasn't here.
Last week?
Yeah.
Well, last week was school vacation anyway, so
the week before that. I let Amy know that I was on vacation, so I wouldn't be here.
Okay. I don't think they told me, but that's okay. It was fine. Okay, so on page 306 in your textbook, the purpose of health insurance is to help individuals and families offset the cost for medical care. It's a contract for protection against financial losses due to illness or injury, and it provides payment of monetary benefits for covered illnesses, sicknesses, depending on what is covered by the policy. The subscriber is the person who holds the policy. Contracts with patients. To obtain health insurance, patients have to apply either through their employer or privately. And with the Obamacare, they can do so. There's a website out there if they want to apply for insurance on their own. Two types of health insurance plans in the United States are privately sponsored and government-sponsored health plans. Most of the health plans out there cover services that are deemed medically necessary. They do not cover elective procedures. With Obamacare, preventive care is now covered, but depending on the type of facility that you work in, you want to make sure that whatever services your provider is doing, you want to make sure they are deemed medically necessary. Some of the health insurance plans, the government-sponsored plans, the patients need to meet application requirements, and that can be age, disability, income levels, occupation. Employer-sponsored group plans. Employers usually sponsor a percentage of the monthly premium, and then the employee picks up the other. It used to be, before the cost of health care rose, that some places paid your monthly premiums for you, but that has changed. And then we have the individual health insurance plans. And again, this can be done online through websites, individually checking insurance companies. And a lot of the individual ones, before, people would have issues getting them because of pre-existing conditions. But now, because of Obamacare, they cannot deny you for pre-existing conditions, which is great.
Yeah.
The Affordable Care Act, also known as Patient Protection and Affordable Care Act, or Obamacare, is out there to increase quality, availability, and affordability of private and public health insurers for over 44 million people. And if you look on page 307, part of the Affordable Care Act says that companies are prohibited from dropping a patient if they get sick or miss an application or make an intentional mistake on the application. Again, eliminates pre-existing gender discrimination. Young adults can now stay on their parents' insurance until they turn 26. Health insurance marketplaces, which are where the patients can go to search and get quotes for how much the insurances are going to be. States will expand Medicaid or main care coverage to 15.9 million people. That's a lot of people on main care or Medicaid. And it requires all Americans to obtain and maintain minimal essential coverage. If they do not, then there is a penalty. And some people, depending on their health situations, if they're a fairly healthy person, and they opt not to take health insurance, the penalty that they pay is still cheaper than what they would pay out in health insurance, and they run that risk that, God forbid, but should something happen, then they're going to end up paying for everything out of their pocket. You can only enroll during open enrollment, so that's another thing they want to be aware of. So if you look down on also 307, it goes over what the Affordable Care Act covers: the ambulatory, ER, hospitalization, maternity, labs, prescription, preventative services. So a lot of things there that it covers. Benefits. Every health insurance contract is tailored to the needs of either the individual or the group policy, depending how it is. Benefits cover the amount lost or the amount that should be paid to the health care provider. And a policy can contain one or any combination. If you look on the next page, just to give you an idea of what the benefits are. So on page 308, hospitalization. It can cover all or part of hospital room and board, and then specific hospital services such as surgery. It pays the maximum amount per day and maximum number of days. For surgical, it will pay the surgeon's fee and a surgical assist. So there are some things that it may not pay. And what a lot of people don't realize is, especially for inpatient stays, a lot of the insurance companies have a restriction on how many days they can be an inpatient before they're liable. So again, something to keep in mind for the benefits. But again, hospitalization, room board, surgery, they set maximum amounts payable per day. Surgical, again, surgeon fee, some pay assistant surgeons, and surgery is an incision, an excision, a removal, suturing, anything like that. They frequently provide subscriber with surgical fee schedule, so they will know what they are going to get paid. Basic medical pays all or part of the physician fees for non-surgical, which can be hospital, home, office visits. And the patient would usually pay a deductible and or co-insurance or co-payment each time they go in for a visit. It can, can have provisions for labs, x-rays, MRIs, CAT scans, pathology, anything like that. The major medical is protection against large medical bills from catastrophic care. It covers most serious medical expenses up to a specific amount, which is the determination of the insurance company. Disability, it protects the earned income against the risk that a disability will make working not able to be done or uncomfortable. It encompasses paid sick leave, short-term and long-term disability. Many policies do not start payment until a specified number of days after sick leave has been established. Payment is made directly to the individual, and again, it's intended to replace lost income. And the disability is usually a percentage of your paycheck. It's usually not the full amount, and again, that's dependent upon what type of coverage you have through your employer. We then have dental care, which a lot of offices can offer. It may not be paid for by them, but they may make it a benefit available to you if you opt to pay for it. Some policies are based on co-payment and incentive programs. Some will have a vision program and may reimburse for a percentage of eye exams or glasses or eye surgery, anything like that. Medicare supplement is a supplemental policy to defray anything that is either not covered by Medicare or is either Medicare's deductible and or 20% co-insurance that the patient ends up owing, because Medicare will pay 80% once they meet their deductible, and the patient is responsible for the other 20%. Medicare supplement that covers their deductible and co-insurance is what we call a Medigap policy. We have liability insurance, which cover losses to a third party, so auto, business, homeowners, anything like that. With the liability insurance, that is going to be something that your practice will want to address as to whether or not you accept liability, not whether or not you accept the patients, but do you want to bill that third-party liability insurance and wait for payment? Some you may get paid within 30 to 60 days. Others, if it's an issue of waiting for the case to be settled, you could wait quite some time before that happens. So, something to keep in mind. Life insurance provides payment of a specified amount on the insured's death. Monthly, some of them provide monthly cash benefits if they are permanently or totally disabled. And sometimes proceeds from the life insurance can be used to meet expenses of that person's illness. Long-term care insurance covers maintenance for chronically ill, disabled, developmentally delayed. Services can be provided on inpatient, outpatient, or at home. On page 309, premiums. So patients that are covered by an employer-sponsored group plan typically share the cost of the monthly premium. Individual health insurance marketplaces also have monthly premiums, which the patients are liable for, because that's the individual plan that they're getting on their own. They're not getting it through an employer. Indigent, elderly, federally employed, military, who seek health care from the government typically would have little or no copay at all, depending on the type of plan that they have. Everybody that has health insurance has a proof of insurance, which is the insurance ID card. If you take a look on page 310, a couple of different cards. Top left is Medicare. Across from that is an Anthem card, Arizona, out of state. Harvard Pilgrim, and it tells us it's a Medicare supplement, so that we would know is secondary to Medicare. The patient should have that Medicare card first. An Aetna plan, Idaho Medicaid card, and a Harvard Pilgrim through University of New Hampshire. So anybody, when they're presenting, should have an insurance card like this. Now where it's the first of the year, we should be asking to get copies of the insurance cards again, because I was checking referrals for next week, and I probably came across at least a dozen, that the insurances have changed because of the first of the year. So I try to make the front staff make it a habit to, okay, it's the first of the year, just ask everybody for copies of their insurance cards. That way we also make sure we have the correct information. Verifying eligibility, so confirming the health insurance to make sure that they are covered on the date of service. And before the appointment is scheduled is when that health insurance information should be being obtained over the phone. The practice management system that we use is one that when we enter the insurance and the patient's ID number, we have the option to verify eligibility. So right then, it will go electronically and let us know whether or not they are covered on that day. Because, again, sometimes people don't realize that they may not be covered because they're out on disability and maybe their health insurance has lapsed, or they may truly know that they're not covered and figure you're not going to check, and if they don't have to pay you that day because they've given you an insurance card, that's one way they can get out of their responsibilities. On page 312, assessing health care. So when the insured patient seeks care, the provider provides the service, and typically they are an in-network provider, because if patients have a plan where if they go to an in-network provider, their copay might be $10, whereas if they go to an out-of-network provider, their copay might be $50. So most of the time, patients are going to try to lean towards their in-network providers. Many health insurance plans do not reimburse for out-of-network, meaning that the patients end up with the majority of the responsibility themselves, or it may be applied to deductible instead of just a $10 copay. The participating providers' contracts. So healthcare providers need to be what we call participating providers with the insurance carriers, which means some fill out lengthy forms and others are nice, simple, one-page forms. They do this through a process called credentialing. And again, that credentialing process is an application that they fill out, and then there's a CAQH website which stores the physician's information as far as schooling and updating medical licensing and updating DEAs and all that stuff. And a lot of these insurance carriers use that CAQH database to verify the provider's credentials and determine if they are going to allow that provider to be participating with them. Once the provider is credentialed, then they issue a contract for that provider to be in network. The contracted fee schedules in the United States, payment for services are typically made after the services are rendered. The provider has 3 commodities to sell: time, expertise, and services. So that's kind of all lumped into how the insurance companies determine how much they're going to pay a provider for the service they did. Like that low-level office visit, the 99211, that's typically a 5-minute visit. So they're obviously not going to reimburse a lot for that because there's probably not a lot involved in that particular visit and or exam. And in years past, health insurance plans have greatly influenced what the healthcare providers can charge. And that still is the case, because a provider can do a surgery that he may feel is worth, like a shoulder revision. The doctor might feel that that's worth $5,000 because of the time involved and everything that needs to happen, but the insurance companies may feel that it's really only worth $3,000. So the physician can charge whatever they want, but there's going to be a big write-off for the provider at that point. And write-offs or adjustments only benefit the provider to a certain point. They can only claim a certain amount on their taxes. So not everything that's a write-off benefits the provider. So we still see sometimes that they do not really delegate, but kind of say what we can charge and what we can't charge. How do they determine reimbursements? Usual, customary, and reasonable, indemnity schedules, benefit plans, and resource-based relative value scales. I'll go over each one of them, but what you will find is most of the insurance companies pay based on fee schedules. They publish their fee schedules. We just got a notice today that I think it's Medicare, I want to say, will be publishing their 2018 fee schedule April 1st. So what's going to happen is all the claims that they pay from now till April 1st, they'll pay on last year's fee schedule. April 1st, if those fees change, whether they're up or lowered, then they'll either take back money from you or they're going to issue you additional payments, which can be a nightmare. So the usual, customary, and reasonable, they pay on the basis of all of or a percentage of what that usual, customary, and reasonable fee is. Charges for a specific service are compared with a database showing other patients for the same service by the same type of physician, or charges to patients by other physicians performing same or similar services within the same geographic area. Because again, an orthopedic in Portland doesn't need to charge the same amount that we charge in Brunswick for an office visit. Again, they can charge whatever they want. The indemnity schedules, they're more flexible yet more costly. Traditional health plans that pay all or share cost of covered services regardless of the provider. This is typically called a fee-for-service plan. And in exchange for premiums members pay, indemnity plan reimburses members or providers when they file claims. The service benefit plans, the company agrees to pay for certain services without additional cost to the patient. So let's say, for example, it might be bariatric surgery, for example. There is no set fee schedule, and the premiums are sometimes higher, but reimbursements are higher. And then we have the resource-based relative value scale. This is one of the outcomes of the physician payment reform by the Omnibus Budget Reconciliation Act back in 1989. They implemented a change to this 3 years later in 1992, which changed the system to a fee schedule. So you will still hear a lot of it referred to as resource-based relative value, but know that in 1992, it actually switched to the fee schedule. And like I said, that's the one that the majority of plans now use. And that fee schedule takes into consideration work, liability expenses, and the physician's overhead as far as office and that type of staffing, that type of thing. On page 314, the privately sponsored health plans, also known as commercial carriers. These are for-profit organizations. They make annual changes to the participating providers in order to negotiate lower payments. Oops. Okay. Blue Cross Blue Shield. This is the oldest and the largest privately sponsored insurance carrier. They offer incentive contracts to healthcare providers to be providers for them. The participating providers write off the difference or the balance between the amount charged by the provider and what the insurance company allows. And that holds true for any insurance company that you have a contract with that you agree to be a participating provider for. So if you charge $1,000, but Blue Cross Blue Shield only allows $500, then that difference of $500 is a write-off. And I like to say my doctor eats it. And then that $500 that they allow, if they pay $400, then the difference of $100 is what your patient would pay. That's what you're allowed to bill them. The other commercial carriers, Aetna, Connecticut General, which is Cigna, Metropolitan, Prudential, big one around here is Martins Point, Harvard Pilgrim, Health Plans, Maine Community, just to name a few. The managed care organizations. This is an umbrella term for healthcare plans that provide healthcare in return for preset scheduled payments and coordinated care through a specific network of providers and or hospitals. The HMOs, also referred to as health maintenance organizations, provide comprehensive health care to an enrolled group for a fixed periodic payment. And typically these are your primary care physicians. Be familiar with individual managed care contract benefits and with procedures for filing insurance claims, because they're all different. Every insurance carrier has different timely filing, has different, if you use a certain modifier, some might require notes, some may not. So knowing what their processes are. Review managed care plans, specific handbooks, contracts, required forms. What I tend to do is I will go out on Anthem's website and I'll search for like an authorization form, and I'll print one off and I keep it in a binder. And that way I've always got the most recent updated forms, and I'll pull them out and change them if they get changed. But that way they're there and it's easier to do, especially if you have to do something quickly. Managed care policies and procedures. Some of the advantages of managed care include that the costs are usually contained or a little bit lower. The established fee schedules are used, so there's no variation. Authorized services are usually paid for. Most preventative treatment is covered, and the patient's out-of-pocket tends to be less than regular coverage. Some disadvantages: access to specialized care and referrals can be limited because your primary care may want you to see an orthopedic within their group instead of an orthopedic that you've had for years, just because they're in that group. Physician choices in treatment of patients can be limited. Paperwork, much more paperwork for HMOs. Treatment can be delayed because you're waiting for authorizations. And unfortunate, it's awful, when we try to schedule patients for MRIs, before, knowing they've got a rotated cuff tear, but we have to verify it with an MRI so that they can have surgery and be comfortable, and we have to wait to get the patient in for an MRI almost 2 weeks later because it's taking us 7 to 10 days to get the authorization. Whereas if they didn't have that type of plan, it would be a lot easier. Again, reimbursement historically is less than a traditional insurance plan. And again, you can see on 314 in the table 16.2, it gives you the advantages and disadvantages of the HMOs. Some of the health maintenance organization, again, it's a plan contracting with a medical center or a group of providers that do both preventative and medical care. They are regulated by HMO laws, which do require them to offer preventative services, and that's typically why it's a primary care, because a specialist typically is not going to do preventative services. Always requires referrals to specialists for pre-cert and pre-authorization, for hospital admissions, outpatient procedures, and treatment. So again, needing that authorization before you can move forward. Providers receive payment according to various structures. There used to be a capitation structure. That capitation has gone away, and again, it is a fee-based schedule now. Most common HMO models are IPA, staff, and group model, as well as PPO and EPO. And I'll go through each one of those, but again, you can see in table 16.3, it gives some examples of those particular models as well. The IPA is what we call Independent Practice Association, group of physicians who are independent. They are under contract to provide services to members of different HMOs in addition to other health insurance plans. And again, this is usually at a fixed fee. Payments to providers by an IPA can be structured either as capitation or fee for service. I don't know if there's any up Bangor way. I know Maine Med has a independent practice association as part of what they offer their employees for health insurance, so I'm not sure how many of those we have in the area. The staff model hires physicians, so the physicians get paid a salary by that HMO. So the HMO owns that network. Medical care is given or authorized by the PCP again, and there's no capitation or fee for service payment for this model because the physicians are paid a salary. The group model, they contract with multi-specialty groups to deliver care to the members. They reimburse physicians group, which is responsible for reimbursing physician members and facilities. And multi-specialty groups may organize a physician association, and group members typically practice together in one facility. So this would be like a big practice with multi-specialties. The preferred provider organization, this is managed care network of physicians and hospitals that have joined to contract with the insurance companies to provide health care, again, for subscribers at a discounted rate, meaning if they go to a preferred provider, again, the patient holding the policy is going to pay less than if they go to a provider who is not preferred. They furnish subscribers with a list so that they can make sure they are going, if they want to a provider where they aren't going to have as much of a liability. Some patients have been with the same providers for years, and even if they're not on their preferred list, they still want to go to that provider knowing they're going to pay more. Provider who joins a PPO continues to treat and bill patients on a fee for service. On 315 on the very bottom, the exclusive provider organization. This is similar to an HMO and a PPO combined. It's exclusive because providers agree not to contract with any other plan. So this would have to be a very big area where this was all it was, because if they agree not to contract with any other plan, they're probably going to end up turning lots of patients away, especially Medicare patients, Maine care patients, whatever. Members must choose medical care from network providers, and it is regulated under insurance statutes, not federal and state regulations. I don't know why they stuck this in on this page, but on the bottom of 315, it talks a little bit about professional courtesy. And just be aware that with professional courtesy, one of the big things is if you are contracted with an insurance company and you are giving a patient a professional courtesy on their copay, for example, you are actually breaching the contract with that carrier. So that carrier can drop you as a participating provider, but you can also end up getting fined and penalized as well. So as much as your providers want to do that professional courtesy, every time my provider says it, I just go out online and I find all kinds of articles that just talks about the penalties and losing your contracts with the carriers, and I give that to my providers, and that carries them over for a little while. And then the next time it happens, I just print them back out and give them back to them, because I understand why they want to do it, but really not a good idea. On page 316, referrals. So patients who seek specialized care have to go to their primary care first, and their primary care will say, okay, we're going to give you a referral to go see that oncologist, for example. Approval or denial of a referral can take few minutes to a few days, depending on the insurance company. Sometimes all the insurance company needs is your PCP to document in your record that they're sending you and how many visits. Others require that you log into the insurance carrier's website and actually fill out forms online, and then you have to wait for them to get approved. There are 3 types of referrals. Regular, which can take 3 to 10 days. And again, usually it is used when your PCP wants to send somebody to a specialist. Urgent referral can take 24 hours for a review. It's when it's urgent, not life-threatening. And then a stat referral can typically be done over the phone, and that is strictly for emergent cases. So for us, a stat referral would be somebody presented to our office with a fracture, and the fracture was an open fracture, and the bone was exposed, and we had to repair it that day. That would be a stat referral. Pre-authorization for surgical procedures. So when you get a pre-authorization for a surgical procedure, you are issued a authorization number or an authorization code. The date on which the referral request was received by the utilization department, date on which they approve it. They will give you an expiration date, so it's not going to, some of them will date it just for that one day that you want the patient to have surgery. Others will give you a window in case that surgery needs to be rescheduled. And it also gives you the diagnosis codes that are acceptable for that particular surgery. And it's real important that we do these pre-authorizations, because otherwise we may have to fight to get paid, and a lot of carriers do not allow you to do retro authorization. So if your provider does surgery on Friday, but you're not going to get to those charges until Monday, by Monday it could be too late for you to try to get an authorization. And again, if you look on 317, it gives you all the stuff that would be on that authorization. Would tell you specifically whether it's for office visit, inpatient, outpatient, and if you look at this pre-authorization request form on 16.3, this can be something that you design that you can use for a variety of health insurances, or the majority of health insurances have their own forms right on their websites. And again, that's something that can always be printed off and used pretty easily. It will also have the name, address, telephone number of the specialist. They'll have a little comment section if anything needs to be put in there. Again, the specified number of visits. On page 318, utilization management and utilization review. This is a form of patient care review by healthcare professionals who do not provide the care, but they're sponsored by healthcare companies. So what happens is, if my provider wants to do a surgery and we go through the authorization process and they say, nope, we're not going to cover it, we can call and ask for a utilization review in which a healthcare provider who works for the insurance company will either talk to the doctor or review whatever we send in and determine whether or not they feel it's a warranted procedure. And sometimes the provider has to go that extra step to do that. On 318, on the bottom, government-sponsored plans. They provide health insurance coverage with reduced or no monthly premiums for indigent, elderly, military, and government. There's a variety of plans, but again, they need to qualify, whether that's by their age, their income, occupation, or health condition. The first one is Medicare. It was established in 1966. And it is for coverage for 65 or older, disabled, and patients with end-stage renal disease. It is broken up into 4 parts: Part A, Part B, Part C, and Part D. And just to go over quickly, Part A is the hospital benefits, and that's something that is automatic for anybody having Medicare. Part B is the medical coverage for physician side of it. Part B is an option. If patients opt to have Part B coverage, it is something that they would pay a small fee for. There is a small deductible, and then other than that, Medicare pays 80%, and they only have 20% responsibility. Part C is what we call a Medicare replacement plan. So it's an HMO version of Medicare. And Anthem, Harvard, Aetna, Cigna, they all offer Medicare Part C plans. And then Part D is a prescription plan with Medicare. They allow a certain amount for the Medicare patients. And once that amount is reached, when they fall into a donut hole area, then the patients are liable for the rest of their prescriptions. So for some Medicare patients who may not be on many prescriptions, this Medicare Part D plan through Medicare might work pretty well for them because they don't have a lot of medications. Somebody who's on blood pressure medications or diabetic medications, this Medicare Part D, they may want to go out and see what other plans are out there for prescription plans because they may find better coverage plans than with actual Medicare. Medicaid. All states and District of Columbia have Medicaid programs, but they all vary. They are all different. You can be eligible for Medicaid in one state and not in another state. Federal governments provide basic funding for the state, and then after that, the states decide whether or not to provide benefits or funding for other benefits. With Medicaid, the physician can accept or decline to treat patients. You do not have to see a main care patient. Physician who does accept Medicaid agrees to the Medicaid payment in full. Medicaid does not reimburse very well. And for the mid-level office visit, like a 99213, I think Medicare pays $24. So depending on the provider, if they're seeing tons and tons of Medicaid patients, it may not be beneficial for them to continue to see all Medicaid patients. So some may limit or close their practice for a while to main care patients. You cannot...
I was just going to say that's one of the reasons that the nursing homes and hospitals are in troubles because Medicare is not paying them back.
Yep, exactly.
I know that's why nursing homes have been closing. They're just not getting reimbursed for the expenses. Right. It's sad.
Yep, it is very sad. And I know a while ago they tried to get some of that money and disperse it to some of the places, but depending on how much was owed to them, it probably was too late.
It was, yeah. I work for, what was Goodall Hospital then. Now it's Southern Maine Healthcare.
Oh, yep.
And we had got a big chunk back, like probably about, 6 years ago maybe more. We got a big chunk, but we were just so in debt with all the vendors. It wasn't really enough to get us out of the hole, so we had to merge. But it's, it should have never gotten, out of control like that.
Yeah, and it's too bad that happens, but, I don't know that there's much that could have been avoided at that point, but, how do you stop it,
Yeah.
With the main care, you can't balance bill the patient for the difference. So if that's all they allow is that $26 for that $150 visit you perform, that's all you're going to get. You can't bill them the difference. You write it off. Examples of those who qualify for Medicaid benefits: medically needy, recipients of aid to families with dependent children, people who receive supplemental security income, people who receive certain types of federal or state aid, individuals in institutions or receiving long-term care or nursing. So again, there's a couple of different ones there. The individuals who are qualified Medicare beneficiaries are what we call QIMs or QIMBY. And with QIMBY, Medicaid will pay for the Part B premium, the deductible, and co-insurance for those that qualify. So if that claim goes through Medicare and it's applied to their deductible, if they qualify for this type of Medicaid, then it will pick up that deductible and the patient wouldn't be liable for anything other than their monthly premium that they're paying to have that Part B coverage. Under Medicaid, there is what we call the CHIP program, or Children's Health Insurance Program. It's a state-funded program for children whose family income is above the Medicaid qualifying limits. Typically 5% of the family monthly income is what the premium is. State CHIP programs cover routine immunizations, prescription, dental, vision, inpatient, outpatient, lab, x-rays, and emergencies. So it's a good program, and if you were probably working in a pediatric office, you're going to see probably more of that than a specialty office, so to speak. Another type of plan is TRICARE. This is a comprehensive health care program for family members of active duty, military retirees, and their eligible family members under 65, and survivors of all uniformed services. It is managed by military in partnership with civilian hospitals and clinics. And all military hospitals and clinics are part of the TRICARE program. Individuals have to be TRICARE or CHAMFA recipient in order to be eligible. They are entitled to retired, retainer, or equivalent pay. They must be listed in what we call the DEERS, which is the Defense Department's Enrollment Eligibility Reporting System. So if they're not in the DEERS system, then they are not eligible for TRICARE until that gets updated. Also eligible for a TRICARE eligible spouse under the age of 65 and dependent unmarried children under 21 or 23 if they are in college full-time. TRICARE has 3 types of plans. If you look on 320 at the table 16.5, they have TRICARE Prime, TRICARE Extra, and TRICARE Standard. So you can see what the difference is by looking at them. The TRICARE Prime is a managed care plan, so very similar to an HMO. The TRICARE Extra is a preferred provider network, and the TRICARE Standard is the fee-for-service plan. So with TRICARE Prime, there's very little cost to the patient for active duty family members. If they're retired, they've got an enrollment fee, a small copay for inpatient stuff. The TRICARE Extra, there's a deductible. And then for outpatient, there's a 15%. Inpatient, greater of $25 or $13.90 a day. TRICARE Extra with the retirees, again, they've got a deductible, and then they're 20%. And then the inpatient, lesser of $250 or 25%. And TRICARE Standard, again, they've got a deductible, 20%, still the inpatient admission, mental health, inpatient skilled nursing, And again, if they're retired, they go up 5% in the percentage from 20 to 25%, and the inpatient cost share $250 to $512. So again, there's some differences there depending on what type of coverage they want and what type of flexibility. The CHAMPVA health benefit program, again, similar to TRICARE for spouses and dependent children, permanent service-connected disabilities or surviving spouses and dependent children. It's handled through the Department of Veterans Affairs. They share with eligible beneficiaries the cost of certain services. Workers' comp. Federal, all state legislators require all employees to have workers' comp for work-related illnesses. The law protects wage earners against loss of wages and cost of medical care from occupational injury. No state workers' compensation laws cover all employees. You have to check with your employer with regards to what their benefits are for workers' comp with your employer. The compensation includes medical care benefits, weekly income replacement benefits if they're temporarily or permanently disabled. Provider of service accepts workers' comp as payment in full. So with workers' comp, you get paid the workers' comp fee schedule. You cannot bill the patient anything else. The employee is obligated to promptly notify the employer, obviously when there's an injury, so that the claim can get started, so that if they do need to see a provider, then the services will be covered. On the bottom of 321, the last type is an employer established self-funded plan. So when there's a large company or an organization that is big, has a big enough employee base, it chooses to fund its own plan. They pay employee health care costs from the firm's own fund, and by doing that, they may sometimes offer or have a third-party administrator that handles all the paperwork and the claims issues. It may not be done by somebody in the office. They hire somebody outside to do it.
Yeah, we use Unum.
Oh, do you?
Yeah.
Yeah. I don't know. Ours is an employer-based. They go through, they offer Maine Community as their coverage, which just went up like 46% for each employer. It was ridiculous.
Yeah.
So in closing, health insurance and benefits can be confusing, not just to patients, but to the offices and the medical assistants and anybody that has to deal with them. Responsibilities include keeping the patient informed, answering questions, or directing the patient to contact their insurance, because I'm sure you find that not many people actually have ever read their insurance policy. I know when I got mine, I'm covered through my husband. I read it. My husband calls me a geek. I'm like, nobody ever reads their policy. I said, I read it so that I know if something comes up, what's covered or what we're going to need to do. And I do it so that I have an idea what to tell the patients about their policies. Because a lot of them just think, oh, I've got coverage, I can have anything done. Well, that's not the case. So
yeah, I always read mine too when it comes through, especially even though we've had the same company, they change, the company changes what they're willing to pay for and things like that. So I always read for the changes, so I like to know too.
Yep, good idea. So using good communication skills, patience, if we do have to talk with the patients with regards to that, and written release given for medical information to the insurance claims processing. And again, that release is typically done when the patients sign their form when they first come in, giving permission for you to bill the health insurance and provide them information necessary to get the claim processed. Any questions on the basics of health insurance?
No, that was.
Nope. All right, so now we'll go into medical billing and reimbursement. And some of this may end up being reiterated, but so medical billing and reimbursement. So this is starting with collecting accurate patient insurance information so that we can submit accurate insurance claim forms. We want to make sure, again, each health insurance company typically has their own submission policies with regards to claims as far as whether or not they can be electronic, how long you have to submit from the date of service. So we want to make sure we're aware of all that. We'll talk about the explanation of benefits, or EOB, and we'll talk about deductible and co-insurance again. So the steps in medical billing: collecting patient information when the patient schedules the appointment, at the time of the appointment, making a copy or scanning both sides of the insurance card. One, because the front is going to give you the ID and the policy number, and the back is going to give you the payer numbers if we are submitting electronic, addresses, phone numbers, anything like that. Verifying eligibility. Now, again, some of the practice management systems out there allow electronic verification. Others, you can log on to their websites, verify eligibility, and some you would need to call to verify. After medical services have been provided, the diagnosis and the procedure codes would get entered into the system so that it would then generate a claim form to go to the insurance company. That would be completing the CMS 1500 form. Again, submitting it either electronic or to paper, depending on the insurance carrier and the size of the practice. Review electronic claim submission report to make sure that it is accepted at the other end. Anytime you submit claims, if you are submitting them electronically, it will tell you if they're received and accepted, or if they are received and you might have two that have been rejected and returned. That way, as long as you're reviewing that report, you're able to take those ones that were not accepted, find out what was wrong with them, and then get them off in your next batch. Meet timely filing requirements of each, again, individual carrier. Post payments in patient's account, either by the explanation of benefit or Medicare refers to it as a remit advice. When we post by the explanation of benefits, most of the time, most offices, depending again on the size, will post, I call it by hand, but they've got the EOB and they're individually posting each line item. Medicare, some practices that are fairly large, you can actually electronically post. Even though they're electronically posted, we were always told to review them because sometimes they may not always post correctly, depending on the volume. So that's another option. Each payment for a procedure line item must be posted correctly in the patient's account. So we want to make sure we're putting the write-off in there and that we're not billing the patient for what was supposed to be a write-off, because that's fraud, and we can run into issues. Once payments from EOB have been posted, then your patient would get a statement with their outstanding balance. So having a way to set that up in your system, how our system does it is, if the patient has never received a bill before, if I post an insurance payment today, then overnight the statement will drop out to the patient. if the patient's a recurring patient and they got a statement, let's say on December 9th for other services, then these new charges that they got won't go out to them until 30 days from their last statement. So just putting it on a cycle. If you look on posting payments, line items, yep. On 326, there's an example of a patient registration form. This doesn't give the patient's authorization for you to bill the insurance. It says that they are aware that they are personally responsible for charges, but there are ones that you should physically have your patient sign saying they give you the okay to bill the insurance. Some information found in the patient's billing record. When the first appointment is made, again, you routinely ask the patient for pertinent insurance information. The more you get ahead of time, the easier it is to refer back to that if a number is transposed or anything like that. So again, here it's got primary coverage and secondary coverage, and that's something that would be scanned into their chart, as well as if you're obtaining a copy of the card, you've got the card to look at. Maybe you can't read the patient's writing, but then you've got the card to compare to. The medical release of information form signed, again, by the patient. Managed care policies and procedures to submit accurate health insurance claims. Medical assistant should establish office procedures. So what that means is we want to make sure that if that procedure or service required prior authorization, that we, or pre-certification, that we have a process for obtaining that. Process of obtaining the dollar amount approved for a medical procedure before the procedure is scheduled. Again, this is similar to a pre-authorization process. Again, by doing that, just by obtaining a pre-authorization or a pre-cert doesn't guarantee coverage, but it does make the process a lot more easier if we have to go back and fight for anything. Also with pre-certifications is if the appointments are scheduled correctly and you can look like this week at next week's schedule and see what they're coming in for, then you're a little bit more apt to get the referrals or authorizations for the appropriate services that they're coming in for. If somebody just writes follow-up on the line and they're coming in for an injection that might require an authorization, we may not know we need that authorization. Mm-hmm. Submitting claims to different payers, to different third-party payers. Did I talk about managed care? Where's my pre-cert? Oh, I talked about pre-cert. Okay. Submitting claims to different third-party payers. So they all accept the CMS 1500 form. However, again, each plan has their own policies or procedures for submission of claims. Again, whether or not they'll accept them electronically, whether or not they have to be submitted by paper. Anthem Blue Cross has just started that now when you submit a surgery, you have to send the op note with it. You never had to send the op note before, but now they actually have somebody reviewing the op notes before they're paying the surgical procedures. Keep a medical billing manual that has those billing and policies and procedures for those payers. Again, that's going to make life much easier for you. Generating electronic claims. If you are familiar with a paper claim, then there's no problem collecting the data for the electronic claim, because the information that goes on the electronic claim is the same that goes on the paper, and your practice management systems, as long as you are keying in that information, when you go to prepare the claim, it puts everything that you've entered in the correct spots. So as long as you're putting it in, it's going where it needs to. Electronic claims transmitted over the internet, again, through what we call electronic data interchange. So the data does need to be accurate or those claims can be rejected. Electronically, they can be submitted a couple of different ways by what we call direct billing and clearinghouse submission. So direct billing is by means of an insurance carrier allowing a provider to submit insurance claims directly to that carrier electronically. So we used to have a practice management system that allowed us to direct bill to 3 places, and that was it. So we had to pick our 2 biggest carriers, which were Medicare and Blue Cross, and then the third, we ended up using a clearinghouse because that was the only other way we could get all of our claims out the door without making a big mess of everything. So direct billing, you can do it directly to that carrier, and Medicare now has their own link, and it's free, and you set it up on your computer and you can submit them directly yourself. The clearinghouse submission, they act as an intermediary between you and the insurance carrier. So what they are doing is they are getting the claims, they're auditing the claims, making sure diagnoses support the CPT codes, making sure that the date of birth matches in the system, male, female, all that kinds of stuff. And then as long as everything's okay, then they submit them directly to the carrier for you. So they're acting as your middleman. Typically, the clearinghouses do charge a fee. So if you are using a clearinghouse, you do want to find out what those fees are. Most of the ones I've seen are about 25 cents a claim, which is not bad because obviously you don't want to spend, $10, $20 on a claim being submitted if you're only going to get paid $40, because then you're losing all the way around.
Yeah.
If you look on page 330, again with using a clearinghouse, they also provide you a report that will tell you the number of claims you've submitted, the errors, will give you specifics on the errors so you know what you need to fix. Again, they will forward the claims to the carriers for you, and they will keep you updated if new carriers are added to their database. It is possible that some clearinghouses may not have an insurance that you use, and in that case, you may need to submit to them directly yourself. Completing the CMS 1500 health insurance claim form. So we will go over this again. 9 times out of 10, you are physically not submitting by filling this out by hand, but so that you know what type of information you need to obtain to put them on there. So most of the providers' offices submit the claim forms for you, and most health insurance payers use the CMS 1500. The form has 33 blocks, and you'll see throughout the book it kind of breaks it down for you. But the first block is the address of the insurance carrier. It's up at the top of the form. You'll see it's section 1. Section 2 is patient insured information. So this is the patient name, address, phone number. Section 2 has boxes 1 through 13. Section 3 is, and you can see the sections on your form on page 331. It shows you section 2, blocks 1A to 1A to 13. Sorry. Blocks 1A, 4, 7, and 11A are for insured individual person's health plan ID number, name, address, policy group number, birth, date, gender, employer's name, if applicable, and whether or not the insured has other insurance coverage. 2, 3, 5, 6, and 10 are for the patient to include the person's name, birth date, gender, address, relationship to insured, patient status, and whether their condition is related to the job, accident, or other accident. Block 9 is about whether or not there is any secondary information, secondary health insurance coverage. Up at the top of section 1, also on the bottom of 330, what ends up happening is when you put what type of insurance they have in your practice management system, what it will do is it will put an X in Medicare's box if it's Medicare, or the other ones, or if it's not listed there, then it will go in group health plan or other, depending on your system. Block 12 and block 13 are for signatures of the patient or authorized person of the insured. Now, typically, we are not going to actually have the patient sign each individual claim form. So when your patient signs that registration form giving you the okay to bill the insurance carrier, that is your, what we call SOF, or signature on file. And as long as nothing drastically changes, you can continue to use that signature on file. You do not have to have it updated annually. Some offices like to have it updated annually just so that they're always current, but completely up to the practice. Section 3A is physician or supplier information. So this would be blocks 14 to 23. And block 14, and you can see these at the bottom of 333. Block 14 is current illness, injury, or pregnancy date. Block 15, if the patient has had same or similar illness or condition, and you would need to enter the date of onset. So 15 is sometimes where we might, or not 15, 14 is where we put like a date of an injury for a fracture, for example. Block 16, the dates entered here are used to help determine an employee's long or short-term benefits. Block 17 and 17B, if the patient was referred by another provider, then that referring provider's name goes in 17. And in 17B, their NPI number goes. And that too, like Anthem Blue Cross Blue Shield, is telling the insurance that we got a referral from John Smith, whose NPI number is this, to see Mary. Block 18, not used for claims from ambulatory care practice. Block 19 is reserved for local use only. So block 19 for us may be our free text. So if I want to put, please see attached records, or maybe add some information about a medication that might be on this claim, I can use block 19 as my free text. Block 20 applies to diagnostic lab and x-ray, or just diagnostic lab services. So again, if you're not billing lab, 20 may absolutely have nothing in there. 21 is your ICD-10 diagnosis. And you will see that we have the capability to list 12 different diagnosis codes. We used to only be able to put 4. So this is a lot nicer to have that flexibility. Block 22 is for Medicaid claim that is being resubmitted, would be entered into block 22. So when you're resubmitting a Medicaid claim, you would have to go out on their website, and it tells you what is accepted in block 22 so that they know it's a resubmitted claim. That way it won't automatically deny when it gets in their system. Block 23 is where we put the prior authorization number. So if we got a prior authorization for Mary to get a pin in her wrist, we have a place in our practice management system where we enter that authorization number. And then when I'm entering the charge, I have to actually link that number to my claim. And as long as I link it to the claim, it will print in that box when the claim is submitted. Block 24A, and if you look, this is on 334. 24A is for the date of service that was provided. So you can have a from and a to date. It may be the same if it's just one day. 24B is the place of service. And as far as the place of service goes, I am trying to see if they put it in here. Yes, if you look on page 336, there are your place of service codes. Again, these are typically programmed into your practice management system. So like if it's done in the office, the place of service would be 11. If it's outpatient hospital, it would be 22. And again, that's all pre-programmed. 24C indicates whether or not the service is performed involved in emergency. So that would have an X on it. 24E is for the diagnosis or reference number. And I forgot 24D, sorry. 24D is for the procedure itself. So that's where our CPT or our HCPC code is going to be. And after your HCPC code, you will see there are 4 little boxes that enable us to put modifiers if we need it. And then you see that e-diagnosis pointer. So what happens with this is if you flip back to the previous page where we had the 12 spots for the diagnosis codes, if I had diagnosis code in 1 and 2, and both of those diagnoses pertain to the CPT code that I listed on line 1, 24D, then the diagnosis pointer would have 1, 2, because it attaches both diagnosis codes to that CPT code. You only need one at least one diagnosis attached, but if your office visit, if you're trying to bill a high-level office visit and you only put one diagnosis code, that may not support it enough, so you want to make sure that your diagnoses can support that. Block 24F is the dollar amount for that service. 24G is the number of days or units. So if we were giving a medication and the medication, let's say, is 10 milligrams and we give 40 milligrams, I would have a number 4 in that unit because it would multiply it when it gets reimbursed. 24H identifies certain services covered under state plans only. 24I is for the rendering provider. 24J is for the NPI number for the rendering provider. 25 is the federal tax ID number. 26 would be the patient's account number according to your practice. 27, does your provider accept assignment or not? So it would say yes or no. If it's yes, the check is coming to you. If it's no, you may have to track it down from your patient. 28, the amount billed on the claim form for all services rendered. Block 29, the amount received from patient or other payers. So this would be in the case of if the patient made a copay, or if Medicare was primary and now you're submitting it to Blue Cross, it will give the total amount billed, what Medicare paid, and then what's left. And that's what they will match up to the explanation of benefits. Block 30, again, the amount left that the patient, Block 30 is the amount that the patient has paid. Block 31, signature of the physician, and again, it's not an actual signature, it's a typed electronic format. Block 32 is for the service facility, so the address of the practice. And 33 is for the address and phone number of the provider that wants to get paid. Most of the time, in our case, 32 and 33 will be the same because it's our practice location, and we only have one now, so it's never going to be different. So again, lots of different blocks on the form, but as long as you're keying that information into your practice management system, it's going to get where it needs to. And again, you can see table 17.1 again goes over each one of those line items in more detail. On page 3, did that not go somewhere? That's missing. Okay. On page 338, reviewing claims before submission. So what we want to do is we want to proofread the form, and it may not actually be the form on paper. It may be what's on your screen that you're looking at. Make certain any necessary attachments are included. So if you're using a modifier that requires the documentation, make sure your documentation is attached. Otherwise, when it gets to them, they're not going to have that documentation and the claim is going to come back to you. Again, follow office policies and guidelines for claim review and signatures. Forward original claim to the proper insurance, either by mail or electronic. If you are submitting claims by mail, so let's say you're handwriting out the claims, you always want to keep a copy. So make sure you're photocopying them if you're not generating them through your practice management system. Enter appropriate information in an insurance log. Again, if you are submitting everything through your practice management system, it's going to already have that log. But if you are doing it the old-fashioned way, maybe you've got the patient ledger, which some small offices still have, you would want to record it on the ledger as far as when you submitted that claim. Make sure patient information matches insurance card exactly, and that's no joke because if the patient's name is Elizabeth, and when she fills out her form, she writes Betty, and you submit the claim as Betty, that's enough for it to be denied. The date of birth and gender has to match. Enter the word none in block 11 if Medicare is the payer. And again, this will be done automatically in your practice management system if it's set up that way. Again, your provider's name and NPI number goes in 17A and B, or 17 and 17B. 27 is the participating provider. Make sure your diagnosis is not missing or incomplete, meaning we want to make sure we've got the appropriate number of digits. Diagnosis coded accurately. Patient gave you the release. Fees for the charges listed individually, so you can't bulk them up all on one line. So let's say they come in on one date of service and they have an office visit, an x-ray, and an injection. You can't add all that up and put it in one line item because obviously it's going to have different codes, which only makes sense. Again, the physician's signature needs to be on the form, but it's actually in electronic format. The tax ID or social security number, depending on what they use, and again, the NPI number. So that's all with the claims. Now we will move on to preventing fraud and abuse. So fraud is knowingly and willingly attempting to execute some means to defraud a healthcare insurer by giving false information to get payment. Abuse in coding are actions that are contrary to ethical standards in the medical office. Now, fraud and abuse, Medicare has their own system out there that they audit for fraud and abuse. And if there's a question of it, then you get nailed on all of it. They won't just, if they find it on one claim, they're going to keep digging. You won't just get penalized on that one. The term intentional is important in defining the difference between fraud and abuse. Violations of the laws governing reimbursement may result in non-payment of claims, civil monetary penalties, exclusion from participating with that payer, criminal, civil liabilities, and in some cases, jail. The Federal Register announces the changes with regards to fraud and abuse. So again, that Federal Register is like 5,000 pages long, but you're able to go out there and get just the changes with regards to fraud and abuse or what they're targeting to make sure you are up on that. Upcoding and downcoding. So upcoding is when providers assign a higher specificity level than the actual code that supports it. So let's say I go in for an office visit. It's a 5-minute visit. They don't review anything. They gave me a shot and I'm good. I leave. But the doctor tries to bill a 20-minute office exam and tries to bill a full-blown office visit with an injection when maybe the nurse only gave me the injection. I didn't even see the doctor. That would be upcoding. Downcoding is when they provide a more generalized code, or a lot of doctors, they do a level 4 visit, which is a pretty detailed exam, and they've spent the time with the patient, they've covered everything, but on the OIG watch list, they said they were watching for that level 4 office visit and they were going to audit that. So because that's a target to be audited, the doctor doesn't want to bill a level 4. He's going to bill only a level 3 because that's not going to stir anything up. He's downcoding. He really supported the 4 and should get paid the 4 and shouldn't be afraid to have it audited. But he doesn't want to stir anything up, so they just downcode it so it doesn't ruffle any feathers. So upcoding and downcoding we want to be careful of. They really do not like that. And if you're downcoding, you're shooting yourself in the foot because you're lowering your reimbursement. You're not getting paid what you truly could have supported.
I think upcoding happens a lot, like with counseling. When my son was younger, he saw a Sweetser counselor in the school, but it was out of our private insurance. And I was getting the bills, and it was saying he was with them for an hour. And I said to my son, I'm like, if you're with the counselor for an hour, that's out of your school day, so you're missing work. What's going on? And he's like, I'm barely with him for 10 minutes.
Oh,
I'm
wow.
like, are you kidding? I'm like, are you kidding me? He's like, no. So I checked with the school themselves, and he was only seeing him maybe 10, 15 minutes at the most, and they were billing the insurance company for a complete hour every time.
Wow.
I was like, what? And they've done that. The counseling thing, there's something weird about it because he's got some issues and he had to go to a facility. Mm-hmm. And I got a claim from my insurance company saying that, he's been approved to see so-and-so till this period, and he's approved for these past dates. And I'm looking at the dates, and I'm like, he hasn't been there in 2 years. So I called my insurance company. I'm like, listen, I don't know what got submitted, but he has not seen this doctor in almost 2 years, and he's definitely not seeing him any of these other dates.
Right.
And they're like, really? So they investigated it and stuff. Yeah, they were like trying to bill the company and all that for visits he wasn't even a part of.
Wow.
Yeah.
Wow.
It's crazy if you don't look at it and catch it.
Right.
Like most people, you don't think about the claims from the insurance companies. It's because it's what covered.
Right.
A lot of times you don't look at it or study it, and you just put it aside. Now I make, well, before anyway, but now I make sure I check all the dates and make sure everything was like accurate, actually happened.
Yeah, because what if each one of those visits you had $100 copay for, and all of a sudden they throw in 4 or 5 extra visits? That's a lot out of pocket for anybody. So yeah, definitely. Wow.
There's that, and then insurance companies usually only cover so many, visits to a counselor a year or so many of that, and then that could foul that part up too. If somebody needed something later on, they're shady sometimes.
Yep, absolutely.
Definitely have to watch it.
Right. Jeez, it's crazy.
It is.
Yep. All right. Is the other person there yet for the insurance cost?
Wait, yep, she's coming in now.
Okay.
Sorry, Karen.
Nope, that's fine. So what I'm going to do is let's leave off right there at the preventing rejection of a claim. Okay. That's probably a good spot to leave off on. So we'll pick up there next week. We've just got a little bit left, and then we'll go into patient accounts, collections, and practice management. And you're getting close there. We're almost done.
I know. I see that. All right, I'll go to the bathroom while she gets settled.
Okay.
I want to see if they have their heater. It's freezing, and I've been frozen.
It is.
They don't have their little heater. I'm going to ask them.
I know. Well, the funny thing is I just walked in. I'm like, isn't it sad that you walk in and you look at the thermometer at 9 degrees, and you're like, wow, it's really feels kind of nice out.
I thought I'd been in work all day until when I went to leave, and it was at like 10:12, and I'm like, wow, it feels really warm.
It feels
like
good.
I heated it out here.
Karen, quick question.
Yes.
I got that email that you sent me.
Yep.
Do I need the ones that I got right, that the computer said I got wrong? Should I let Jamie and Amy know about that so they can adjust the grade, or should I just?
Yep.
Okay.
If it makes a big difference in your grade, then yes, I would definitely have them do that.
Because there were a handful that were right. Like I had them right, but they had them wrong. So
yeah, and you can, and Jamie can just override it. Some people, if it was like borderline from a difference of like a 60 up to a 70 or something like that, most would, because they'd want to make sure that grade passes. If it's the difference of going from an 80 to an 86 or something, that's up to you. But because
I think it would bring me up almost a full letter grade getting those adjusted. So I think it would bring me from like a low 70 to like a high 80. I think I want to do that.
Yep, definitely. Yeah, we've tried to talk to the publishers before about the errors when they came up for the following year, when they updated, and for some reason those ones might get corrected, but then there are others that end up happening. So I don't know where the disconnect is, but
is it maybe one addition to another? Because it almost seems like, in reading the question, it seems like it's a quote unquote last year type of error.
Right. Yeah, and it could be, and like that one with the amount, the 130 to the 150, I put that it was a typo, but if last year's was 130 and they carried it over, then it was just that. So
yeah, that question drove me bananas. I sat there for maybe 5 minutes during the exam, and I'm like, I know the answers. Like that was like one of those weird like math type things that's in the book. That was here. It's like, 150. I knew 150, and I'm looking at it going, all right, well that means it has to be this answer because it can't possibly be 130. That's too little.
Right.
And when I got it back, I'm like, no, that's not. No, that's not right.
I know, that kind of stuff drives me crazy.
It's like there's certain things I know we need to like, know off the top of our head, like certain figures. Like, okay, when you're doing this, remember it has to be more than this amount for this to happen, or like sending things to collections. It's like I know, okay, just from my job, it's like no more than if it's less than $10, it's not any sense because you're just throwing away more money. So it's like little things like that. It's like 150 just stuck in my head.
Yep, you were right. So I think we left off on page 383 roughly, didn't we?
I think so, yeah.
Yeah. So we'll just finish up talking about Blue Cross, and then we'll go into Medicare, and that probably is about as far as we're going to get. And then next week we will do Main Care and Tri-Care. And
yeah, I'm really interested in because with Medicare,
yeah,
a lot of stuff that I've noticed comes into play like in these few months, like January, February, March are really big Medicare because you've got your deductibles. I mean, and I know that goes across a lot of insurances, but Medicare is real picky about certain things with regard to their deductibles and what they will and will not pay for, and the guidelines of like, because we see a lot of because my understanding from my coding class was that Medicare does not pay for foot care for patients. They don't pay for like nail debridement, that kind of stuff. But they do. It's a gray area. And you have to meet certain criteria, and they're very specific in what the criteria are. And then even when you meet the criteria, you have to be within a very set period of time that you can be seen. So if you're seen like 1 day sooner than you're supposed to,
it's too soon.
Because they're that specific. And then they change the guidelines too, year to year. So patients that may have fallen okay, all good, all of a sudden don't because they changed the criteria. So
and that's why some of your larger practices, like hospitals or what have you, they have individual people in their billing department strictly that do just Medicare claims or just Anthem claims. That way they can stay updated on all those changes a little easier than like me, who have to get updated on all the carriers because it's only me. But depending on where you work, it's you could get in a place like that where you can be like Anthem or Harvard or Main Care or whatever, and then you're more apt to have a little bit more control over the patients and making sure they meet those requirements.
Okay. And isn't that normally where they would put a new, like if, obviously when we're done with our classes, we're coming in, we're entry level. Isn't that normally what they do with an entry level biller? When
Depends
they put
on the
them
practice.
Like one specific? So
Depends
it depends
on the practice.
Okay.
Because like my practice, we had, I was trying to think when she came. It was probably maybe last April. And she had just finished her coding class. Other than that, had no experience yet. So she came in as entry level to the billing department. But because we're such a small practice, we're not broken up like that. So she came in and did a little bit of everything. She was doing, charge entry. She was doing follow-up on claims. She was doing collections. So I think it just depends on what type of practice it is and what's available. Okay. So.
Yeah, I didn't know if, like, as a, because we'll be, new billers, new people, how when we're looking at the job boards and stuff, obviously looking at entry level stuff. But even some of the entry level stuff, they want you to have a certain amount of experience. So that's why I was like trying to figure out how to market and how to gear my resume, because if they're, wanting someone that just knows everything or just knows a specific insurance,
Right.
how do you handle that interview?
Yeah. And for the specific insurances, what you can do too is like on Medicare's website, you can go out and do their webinars, and they're free. So you can do their webinars on certain things like modifiers or something like that. So if you wanted to do something like that, then you'd have that as, your Medicare training, so to speak. I know Maine Care does webinars as well, and so does Anthem and Cigna. But yeah, just look for like insurance webinars if you want to, kind of get a feel for what's out there.
Oh, awesome. Thank you.
Yeah. All right, so we'll pick up finishing the Blue Cross private and managed care, and then we'll move on to Medicare. On page 383, the payment models and mechanisms. The concierge medicine is not anything you will find around this area. But because the insurances are paying less, there is an increase in documentation and paperwork. So some physicians opt to collect a monthly or annual retainer from patients, and that it can range depending on what the provider wants to set it at. Again, you won't see that in this area. Cash only practices. If the providers don't want to deal with the hassles of the insurance companies, again, rules and regulations, local coverage determination, medical necessity, they could do strictly cash only and do whatever services for the patient as long as they are paying out of pocket for it. The value-based reimbursement, this was with the Affordable Care Act. The fee-for-service model rewards volume and intensity of service. Again, we've kind of gone away from the fee-for-service. Ours are more fee schedules, and we do have quality reporting that we'll talk about with Medicare. Paid for performance, there is compensation or bonuses complying with certain goals for some insurance carriers. For example, if they immunize 80% of their patient volume in the primary care practice, they could qualify with a certain insurance company for a bonus that year. Sometimes the pay for performance has to do with whether or not you can become a preferred provider instead of one of those non-preferred providers. Bundled payment episode of care. Providers agree to accept single fee to deliver all medical services for one patient for a specified procedure or condition. So like, for example, hip replacement. So with this particular carrier, they would say from start to finish, I will do all that patient's care for this amount. Hopefully nothing goes wrong as far as complications or anything, because they're not going to get paid anything more. So they're basing it on everything going smoothly. Patient-centered medical home. The medical home is a single team managing better coordination of medical care that agrees to provide more services. It is paid a negotiated fee for service plus a monthly payment per member per month. Again, probably not going to see a lot of those around. On 384, the shared savings, again, not much of that around. It's just a combination of payment systems, so it can be fee for service, pay for performance, the bundled, global, anything like that. Shared risk, providers receive performance-based incentives to share cost savings of excessive health care delivery. It's agreed upon budget with the payer and provider. Again, we don't see a lot of this in our area. Maybe your more highly populated areas, provider-sponsored health plan. So a larger provider network or hospital system assumes 100% of the financial risk for insuring the patient population. So it collects premiums from employers or individuals and then directs how the care is delivered to those patients. This, they have to have an insurance license, they have to have an approval from a health plan in the state that it's going to operate in. So a lot involved in that one. The capitation models, again, these are managed care plans that can range from fee-for-service and capitation to salaried physicians. We don't, again, have a lot of those around here. The contract capitations as well. Just be aware, capitation, it's based on the concept of paying physician for actual patient visits or contacts. So some of the insurance carriers used to say, you have 25 primary care patients, we're going to pay you $1,000 each year per patient. And that's what they would get paid, $1,000 per patient, whether or not they saw that patient once or whether they saw that patient 5 times. So with this contact capitation, they physically have to see the patient. It has to be a visit. Case rate pricing, this would be for specialists. And again, typically you are not going to see that around here. It's high volume, expensive surgical procedures. Stop loss limit, that means if the patient services are more than a certain amount, the physician can begin asking the patient to pay. Contract payment time limits. Prompt payment laws require payment within 30, 45, 55, or 60 days. If the insurance companies do not pay you promptly, because they're delaying it in some form, then you will see that when they do finally pay you, they typically will pay interest. If it's that they denied the claim because there was something wrong with it, you had to fix it and send it back in, that's not going to qualify for that time frame for them paying you timely because there was something wrong with it and you had to submit it back in. But if they're sitting on it on their end for some reason and just not paying it, then that's when you will see those interest payments. Monitor payments from all managed care plans. Note whether the payment received is less than the agreed amount in the contract. The reason that we do this is because there are times when the insurance carriers will not pay the appropriate amount for a particular procedure. Now, it can be intentional, but it also could be that they're looking at last year's fee schedule instead of the new fee schedule. By watching those and make sure we're getting reimbursed properly, then we're making sure that they are adhering to their contract that they signed with us. And we don't have to worry about getting paid incorrectly. If they are not being processed properly or in a timely manner, you can write to your plan representative. You can list those claims that are unpaid. You can send a statement to the director of the managed care plan saying if it's not paid, the benefits manager will be notified, slow paying accounts. We're going to be renewing the contract, so maybe our provider will no longer be participating. You can take examples and statistics to the negotiating table, so when you're renegotiating the contract or your provider's renegotiating the contract with Anthem, you can say, well, look, overall, we submitted 5,000 claims to Anthem, but over 50% of them were not paid timely. So we're going to renegotiate our contract. You may want to use that, and maybe you can negotiate higher fees. The statement of remits is also referred to as a explanation of benefit, or in the case of Medicare, it's called a remit advice. If you look at the bottom of this page, This is an example of a remit. You'll see in the far column it lists the patient ID number and their name for this particular one. It gives the date next to it. The POS is that place of service. Then it gives the unit number, the CPT code and a description, the amount that was billed, the amount that was allowed. This particular plan is a capitation plan, so you'll see that there's an amount withheld in the risk column. So that's something that with those capitation, if there are amounts that are withheld, what ends up happening is at the end of the year, when they review everything for that provider, if certain criteria is met, then that amount that was withheld, that provider could end up getting back. Otherwise, he may lose it. But again, you don't see too many insurances that use this type anymore. What, if any, copay for the patient, and then the amount paid. And in this case, there's no codes in the adjustment column, but most of your explanation of benefits will have codes that are on there specific to the insurance carrier, letting them know what possibly was wrong with that particular claim or anything like that. You want to make sure you check your payments against your contract again. On 386, managed care plans vary in financial reimbursement structure. So again, good practice management software is designed to handle each plan separately to eliminate mistakes. So earlier I talked in the MA class about electronic posting. There are so many things that when you post electronically that it may get missed. If you are doing it manually, so to speak, then you're more apt to pay attention to what they're allowing and what they're paying you so that you make sure that those amounts are correct. The fee for service, some medical practices handle managed care patient accounts the same as they do for fee for service. So if the plan allows a flat copay for each visit, then that's what they accept, that copay, period. If you look at the bottom of 386, this is a patient ledger. Now your practice management systems kind of do a patient ledger, but it looks a little different. But you'll see that it gives the date, what the services were, and in this case they're just giving the description instead of the code, what the charge was. So here the charge for the surgery was $4,000. And then the insurance, we got the explanation benefits, and the adjustment was $600, and that would leave a balance of $3,400. Then the patient's responsible for, or the patient paid co-insurance payment, $680. That was the patient's copay. So they're deducting that off, and now there's $2,720 left. And that's what the insurance company paid. And then it left zero for a balance. Again, the computers will do it a little differently. They did an individual line item for each one here. You could probably do it a little differently to save on line items, but depends on what your system's going to allow. The year-end evaluation, the withhold, again, depending on the contract, they may retain a percentage of the monthly payments, and then at the end of the year, again, they look at everything. They may keep that to cover operating expenses, or sometimes some of that comes back to the provider. On 387, this is a managed care plan when a payment is on a fee for service. So again, it's showing what is disallowed, what the withhold is, and then what the charge is. Managed care plan that withholds a percentage of the allowable must be tracked in the physician's account receivable so that it's not written off as a bad debt. Because it's not a bad debt, it's a withhold. So there should be a way to document a withhold from an insurance company. It's not a bad debt. And we do. We have a WH If an insurance company, rare, but we may have one a year, or a BD for a bad debt if it was a balance that a patient never paid, for example. Capitation versus fee for service can be an asset for the medical billing specialist to have some knowledge of the reports for financial management reports. Sometimes you're going to be included in that. Again, it depends on the practice and who's involved in those reports and what type of information that they're looking for. The practice manager may be the one that's reviewing all those reports. The accountant may be the one. You may just be asked to generate those reports, but sometimes it's nice to know what those numbers mean so you know what you're looking at. Compare your capitated payment amounts plus your co-payment amounts with the discounted amount. That gives us an idea if we received adequate payment for the services. So again, if we go to renegotiate that contract that next year, we'll know if our numbers are on or if we should be asking for a different contract with higher payments. If an MCO declares bankruptcy, such as through Chapter 11, it is obligated to pay all bills incurred before filing. However, sometimes another entity may take over the plan and all services incurred after filing are paid by the new payer. So again, this would be an insurance company that files bankruptcy. They are entitled to process and pay the claims that were filed prior to them filing. If you look on 388, again, you'll see this is just a worksheet that they've used for capitation. So they're showing with this particular ABC insurance what the charges were, what the capitations were, what the co-pays were, and again, it works out to the end of year totals. So the charges were $3,500, but the capitation for 130 members and 135 members or whatever it worked out to was $6,880 and then a $500. So again, that helps them know whether or not that particular plan is working out as far as them being a provider for capitation. Some clauses within contracts can allow a physician to withdraw from seeing managed care patients or leaving the MCO if it does file bankruptcy. You don't have to continue with that next company that takes over for them. Bankruptcy courts have broad powers to prevent physicians from leaving, though, because any company that goes bankrupt, if all the physicians leave that company and a new company takes over, there aren't going to be any providers participating with that new insurance. So they're hoping that does not happen, but sometimes in contracts you can find wording that will allow them to do that. So that's just a brief overview of the Blues. Now we will go on to Medicare. And there's lots of things within Medicare. Social Security is one of the United States' most important domestic programs. It goes way back. I believe I said 1966. It came up in the MA book. But the policies and regulations, Medicare is administered by Centers for Medicare and Medicaid, or CMS. It is divided into 3 divisions, and they each have their own responsibility. So the Center for Medicare Management oversees the traditional fee-for-service, and they develop payment policy and management of fee-for-service contractors. The Center for Beneficiary Choices provide beneficiaries with information on Medicare, Medicare Select, and the Medicare Plus programs, and the Medigap, or the secondary policies that pick up Medicare's deductibles and co-insurance. The Centers for Medicaid and State Operations focus on federal state programs such as Medicaid, or Main Care here, or the CHIP program for kids, as well as CLIA, which monitors the laboratories in hospitals and doctors' offices. And CMS also enforces insurance portability and transaction code set requirements of HIPAA, meaning they're making sure that the claim processing is all monitored and all HIPAA compliant. So, Social Security, take applications for Social Security. Within or part of Medicare, you will see some patients have what we call railroad Medicare benefits. If they receive Social Security or railroad benefits, they will be automatically enrolled in Part A and Part B, starting on the first day of the month that the individual turns 65, or they have enough applicable work credits that are equal to 10 years of full-time employment. So you will see that in 2000, retirement age gradually increased for people born in 38 or later. By 2027, full-time retirement age will be 67 for people born after 1959. If the individual is younger than 65 of age and disabled, they automatically get Part A and Part B after getting Social Security disability or railroad benefits. So they've got to be 65, retired on Social Security, 65, retired from railroad or civil, disabled, children or adults with chronic kidney disease, or be a kidney donor. The children and adults who have chronic kidney disease, they need to require dialysis, and they have to have a diagnosis of end-stage renal disease. So a few requirements there that need to be done. All persons who meet one of the previously stated eligibility requirements are eligible for Part A, which is the hospital coverage. That is at no cost to the patient. Those that elect to take Part B, which is the outpatient coverage, will pay annually a monthly premium. That monthly premium can be deducted from their Social Security check if they wish. And if you look on page 393, you will see on this Medicare card, it will tell you whether they have Part A and Part B, or just one or the other, and what date that went into effect. So again, you don't have to take Part B. Part A you get automatically. So everybody would have a Medicare card with Part A on it, but it doesn't always have to have Part B on it. So again, make sure, we'll talk about it, but make sure with the health insurance card that you are taking a copy of that as well. So with the Part A, which is the hospital benefits, hospital covers up to 90 days, nursing facility up to 100 days, home health services, psychiatric hospital, hospice, and respite care. The Part B, again, the medical expenses, outpatient, clinical lab, home health, and blood work. We'll talk about Part C. Let me just see if Part C, I'll talk about Part C in just a minute. Want to mention briefly about the illegal immigrants. That is somebody who's not a citizen of the United States. They belong to another country. In the Medicare program, an illegal immigrant can be eligible for Part A or Part B, but they have to have lived in the United States as a permanent resident for 5 consecutive years. So if they do not fall under that certain requirement, then they are not eligible. Again, be aware of the card. Now, if you look at this member's ID number, after the ID number, there is a letter. And if you look on 393, the letters after the Medicare number on the patient's ID card indicate the patient's status. So A is a wage earner. That means that they worked, they earned their retirement. B means it's their husband's social security number, so they did not work. D, they're a widow. So typically that would be the social security number of their spouse that passed. HAD would be a disabled adult. C, disabled child. J, KL, or JL, special monthly benefits, so they've never worked under Social Security. So if you had somebody show up with those letters, you'd want to check what those special benefits are, because they may not be something you're providing. M would be Part B only. And T, they are entitled to hospital and medical insurance benefits, but they're not entitled to monthly Social Security. I mentioned briefly Railroad Medicare, and with Railroad Medicare, the A comes in front of the ID number instead of at the end. So that's one way you can tell the difference between a Railroad Medicare and a regular Medicare. Railroad letter will come at the beginning of the ID number. You can see on 394, Railroad Medicare has different letters. So they're not the same as regular Medicare. And again, they will be prior to the number. So you want to be aware of those different letters and what they stand for. So again, we talked about Part A and Part B. So now on to Part C. And if you take a look on page 395, you will see a table 12.3, which gives, this is Part A only. So for example, with hospitalization, the benefit would be for the first 60 days, Medicare covers all but $1,260, which is the deductible, which the patient pays. If they're in there 61 to 90 days or 91 to 150 days, the member, $315 a day is what they pay. So sometimes what the hospitals will do is if they have a patient and they're getting close to that 60-day mark, they will discharge them. And then they come back in and they're readmitted again, so they have another 60 days, but the cost is still less than the $315 per day. And again, what hospice and blood, home health, everything like that, what they cover. With the Part B coverage, I mentioned that's the outpatient, the medical expenses, that's a DO, an MD, doctor of dental surgery, podiatrist, and can be a chiropractor. But there are also non-covered services for both Part A and Part B. Again, routine foot care with Part B, eye or hearing. If you look on 396, 397, 98, and 99, you will see that that is all Part B and what the services is and what their coverage is. So, for example, diabetes screening. They cover it twice a year for glucose monitors, test strips, and lancets. They pay 100% of the approved amount. Patient pays nothing. But if it's diabetic supplies, it tells you what it includes, but then they only pay 80% after the deductible. So again, depending on the services that you're providing, you can create your own coverage like this grid so that you know what you're going to be able to help explain to your patients on what they're going to be responsible for. And again, you can see everything, lab services, mammos, pap smears, physical therapy, pneumococcal vaccine once in a lifetime. Can't have more than one. Nothing cosmetic unless it's caused by an injury. And what you'll find again with most of the insurances is cosmetic is not medically necessary, so it's not going to be covered. So that would be something you would be looking for from the patient. So on
Karen?
$3.99. Whoops, sorry.
Karen, can you give me that's okay. Can you give me a quick, like, an example? Because I want to make sure that I get this. So for an example, a few of these say Medicare pays 80% of approved amount after the deductible.
Right.
So patient comes in for X service,
Yep.
comes in January for that.
Yep.
Now, that's going to mean that they have to pay the full amount because they have not met their deductible for the year?
No, with Medicare, you're always going to submit to Medicare first.
Okay.
But around the first of the year, yes, you know those patients probably have not met that deductible. But the Part B deductible is typically, I was trying to think, I don't even know that I paid attention to what it was going to be this year. I think it's like $174. So what happens is you submit that claim. Let's say your claim's for $500. They'll apply the $174 towards the deductible, and then they'll pay 80% of whatever's left, and then tell you if there is any co-insurance for the patient. And then depending what they have for a secondary insurance, let's say they have Anthem. The Anthem plan that they have may cover Medicare's deductible and co-insurance. It may only cover the co-insurance, and the patient may be liable for the deductible. It depends on what the secondary covers. Not all secondaries to Medicare are going to cover deductibles and co-insurance. I've seen a lot that the secondary plan has their own deductible. So sometimes not only does the patient need to meet Medicare's deductible, but they have to meet the secondary's deductible too.
Okay. So essentially what this is saying is that, so once they've met the deductible, once they've met that 174, whatever the magic number is, because that goes with all insurances, you meet
Yep.
that magic number, then after they've paid that, then Medicare will pay 80%. So say that same procedure, there now it's like June, and they're
Yep.
coming to have the procedure, and it's, the procedure's $120. They've already met the deductible, so the Medicare will pay 80% of that $120, and then subtract any co-insurance or whatever that
Right, but what-
that the patient's required to pay, and then that will be what Medicare will pay. Correct?
Right, but Medicare pays 80% of their allowable. So remember, what you bill may not be Medicare's allowable.
Okay.
Excuse me. So let's say for that service, you bill $200. So if you took that $200 and say, okay, the patient's going to be responsible for 20%, which is roughly $40, I base it on the amount that we charge, and I tell the patient, your 20% is roughly $40, but I have to wait until I get what we have to write off. Because that $200 that we charge, what if Medicare says we only allow $100? That means the patient actually only owes us $20 instead of $40.
Right. Okay.
Yep. So
Okay,
our
so-
Medicare
so
patients or
once they
anybody
do
that
their-
has co-insurance, we typically will not collect that up front until it's gone through the insurance.
Okay.
Yeah.
All right. Thank you. I think I got it now.
Okay. So the Part C on page 399. Part C had to do with the Balanced Budget Act of 1997, and Part C is what we call the Medicare Advantage Plan. This was introduced in 2004, and in 2006 it was replaced by what they call Medicare Choice. But what it does is instead of the patient having Medicare Part A and B and a supplemental insurance, the Medicare C or the Medicare Advantage Plan acts like an HMO and it replaces their Medicare. Now, the problem with this for some patients is that, remember, Part A you don't have to pay for. Part A you get automatically. Part B you are paying a monthly fee for. But in order to take a Medicare Advantage plan, you have to continue to keep Part B. So you're going to pay for Part B, and now you're going to pay for that Advantage plan. You're not going to use your Medicare. You're going to use the replacement plan instead. And the replacement plan acts as both primary and secondary. So let's say with that Medicare replacement plan, instead of having the $174 deductible and then it pays 20%, the patient now has a $50 copay every time they come to the office. So what the members have to keep in mind is with the Medicare Advantage plan is if they're paying $50 for every visit, and let's say they're seen once a month, is what they're paying out of their pocket cheaper than the deductible and the 20% that they would pay if they just used their regular Medicare. Because you can't just get rid of your Medicare. You have to keep those.
But we have some patients that have a Medicare Advantage plan, and then they also have main care. So is main care considered their tertiary, or is it still considered their secondary to the Medicare Advantage?
The Medicare Advantage plan replaces Medicare. So if they qualify for main care, that is considered their secondary. But of course, by qualifying for main care, they're meeting income requirements. And my thing about that is if they're meeting income requirements for main care, they're paying for that Medicare Advantage plan. Now, I don't know what they're paying monthly for that Medicare Advantage plan, but if they weren't paying monthly for that Medicare Advantage plan and they just used their regular old Medicare, they may not need the Medicaid benefits. Because, like I said, you're paying for both insurances at that point.
Okay.
But the Part C is available in the HMO plans, the point of service, the PPO, so all of those plans. So they can take a plan where they have to go through their primary care for everything. They can take a plan, preferred provider organization. They can do the point of service where they have that flexibility to go where they want, when they want. All depends probably on how much they pay monthly for those plans, and then that would determine what their copays and deductibles are. The Part D is the prescription drug coverage. And again, you can join a Medicare prescription drug plan that helps drug coverage in addition to your original Medicare plan. You can join a MA plan, Medicare Advantage drug plan. You can go outside of Medicare, and there are numerous drug plans outside. AARP has their own drug plan. Periodically on TV, you'll see these prescription reduced cards that you can get for a small monthly fee. That helps with prescription plans, so a lot of different options there. If you enroll, you pay a monthly premium. That does vary depending on the plan. If you do not take a Medicare drug plan when they first enroll and you decide to enroll later, you pay a penalty. So that's another thing. You want to find out what the penalty is if you're not taking it out when you're first eligible. Because if you decide you want it later, the penalty might be more than if you just take it out now or when you're eligible. And then, again, they pay an annual deductible. That varies from plans. And then they pay a copay of the drugs. Most Medicare drug plans have a coverage gap, which we call the donut hole. This means that there's a temporary limit on what they cover for drugs. So if the patients go beyond what that drug plan covers, so let's say it covers $5,000 worth of drugs in 1 year, but the patient's a diabetic and maybe their medications that they take total $15,000. Once they reach that donut hole of $500, whatever's over that, they're responsible for 100% out of their pocket. So they would be looking at $10,000 that they would be paying. Now, yeah, they can go out and get another drug coverage plan in addition, but everything you get in addition, you're going to be paying more for. And does it, or will it, also have a donut hole and not have that coverage that they need? So you have to be careful when you're looking at those. Some of the prescription drug plans will only cover generic, not brand name. Again, something to keep in mind. Prescription drug plans refer to the drugs in their formularies by tier numbers. So tier 1 represents generic, has a lower copay. Tier 2 is brand names, higher copay. Tier 3 are non-preferred drugs. They may have either a copay or a percentage of full drug costs associated. And then they also have a classification with an S, which represents specialty drugs. And that requires a percentage of total cost of the drug. Some of those specialty drugs would be barbiturates, benzodiazepines, cosmetic, symptomatic relief of cough and cold, weight loss, erectile dysfunction, fertility, and prescription vitamins or minerals. A doctor who provides a drug that can be covered by Part B or D needs to clarify the condition on the prescription form, which means they need to provide a diagnosis. With Medicare, for providers that prescribe electronically as of 2010, if they meet certain criteria at the end of the year, they will get a bonus for sending prescriptions electronically instead of written. Again, if you are going to be, this would be more for pharmacies, but if you're going to be supplying meds, you want to make sure to get a copy of the Medicare Part D coverage card. Railroad retirement benefits, the premiums can be, again, automatically deducted. This is entitled to benefits for covered services at a qualified American facility. Some may be a member of Railroad Hospital Association, prepayment plans, or a contract with Medicare. The railroad benefits, again, they're typically most of the benefits that Medicare covers. They still may have their own local coverage determination, so that's something, if you're seeing a patient with Railroad Medicare, check their list of covered services so that if it is something you are doing, you make sure, if it's non-covered, that you are getting the patient to sign a advanced beneficiary notice. Railroad Medicare also refers to their remits as a remit advice, not an explanation of benefits. Medicare, it doesn't mention it in here, but Medicare contracts, they have contractors that bid to process their claims and payments. So I don't know how many years it is. I don't know if they do it every 3 years or every 5 years. But it used to be National Heritage Insurance Company, and that is who we would submit all Medicare claims to. They processed the claims. They paid the claims for Medicare. The company now that takes care of all Medicare's claims and payments is called National Government Services. So when their contract is up, there will be other companies that put bids into Medicare. So when that happens, you may not be sending your Medicare claims to NGS anymore. You may be sending them to a different insurance carrier. So just be aware that Medicare does use those type of things to process their claims. Employed elderly benefits. There are federal laws and regulations. There's the Omnibus Budget Reconciliation Act, or OBRA. There's Tax Equity and Fiscal Responsibility Act, TEFRA, Deficit Reaction Act, and Consolidated Omnibus Budget Reconciliation Act, or COBRA, and the Tax Reform Act. So there are all different types of benefits. federal laws and regulations out there for employed elderly patients. If you look on 401, we also have some additional insurance plans. So determining whether or not Medicare is primary or secondary. You ask the patients if they have another insurance. You copy the Medicare card. You copy their secondary card. You can call the carrier. You want to make sure that you're billing the primary insurance correctly and not billing them in the wrong order, because that can delay your claims being paid. Now, we have patients come in all the time that they'll give us their Medicare card, and then they'll give us an Aetna Medicare replacement card. Well, that Aetna Medicare replacement is their Part C coverage, so that should be the only card that we're billing. We're not going to submit any claims to regular Medicare, but a lot of times the patients don't know that. I would highly recommend, when you are looking for a practice management system, that you look into a system that does electronic eligibility. Because when you do electronic eligibility, I love it. Ours will come up and tell us if the patient gives us Medicare and gives us something else as secondary. If they have a Medicare replacement plan instead, when we do the electronic eligibility check, it will come up and tell us member has a Medicare replacement plan, not Medicare. And we know to ask the patient for the coverage. They just don't realize that that's what that is. They just have given you all their cards. Medicare managed care plans. Again, the HMOs, the risk plan, the cost plans, carrier dealing prepayment organizations, Medicare and Medicaid. So sometimes patients will have Medicare and Medicaid both. In that case, we bill the Medicare primary, and then it goes to the main care secondary. With the main care secondary, I talked to a main care or Medicaid rep the other day, and it used to be that main care would cover the Medicare, like the 20% and the deductible. Well, because of all the budget issues that main care has with the state, what they are now doing is if Medicare pays more than what main care allows, main care is not going to pay anything additional. So you're going to submit it to main care, but don't be surprised if they don't always pay. It's going to depend on what the primary pays you, and then that will determine whether or not main care is going to pay you anything in addition. The Medicare Medigap policy, again, the Medigap acts as a secondary to Medicare. So typically your Medigap policies will pick up Medicare's deductibles and co-insurance. An example of a Medigap would be Companion Plan, Blue Cross Blue Shield, or AARP, for example. And what happens with Medicare is if your patient has a secondary insurance and Medicare will submit the claim to their secondary, on the explanation of benefits, it will say claim submitted to AARP. So you know that Medicare has already sent that claim on to the secondary payer. If there's nothing listed there, then you know that Medicare either did not have the patient as having a secondary insurance, or Medicare doesn't have the capability to submit to that secondary carrier. So that's typically what your Medigap programs are. If you look on 402, there's those federal laws that affect the elderly. There's the omnibus that I talked about, the tax equity, deficit reduction, the COBRA, and the Tax Reform Act, and what each one of them consists of. Medicare as a secondary payer. In some instances, Medicare is secondary. This would be in the case of an aged worker under a group health plan with more than 20 employers or employees, then Medicare would fall as secondary. Disabled individuals age 64 or younger who are covered under a group plan with more than 100 covered employees or covered under a family member. Medicare beneficiaries under an employer-sponsored group health plan that have end-stage renal disease during the first 18 months that they became eligible for Medicare. Cases of workers' comp when the injury or illness occurs at work. Individuals currently or formerly employed with black lung disease, and they fall under what's called the Black Lung Program. Individuals receiving benefits under Department of VA and Medicare. Individuals covered under a federal research grant program. And an automobile accident such as medical no-fault cases or a third party. So there may be situations where Medicare is secondary. But again, that's where it pays to have that electronic check or take the time to make those phone calls so that you are submitting to the correct carrier first. On the bottom of 402, managed care plans. Again, these are your HMO organization, risk plan, cost plan, the dealing prepayment organization. So when a primary insurance is managed care, it typically has fixed co-payments. The practice is paid a capitated amount. There will be an explanation of benefits. You have the patient sign a statement explaining the situation. Typically that, again, if you look on page 403, this is just a small sample. Ours is put on our registration form, but it gives the patient name, Medicare number. In this case, for this capitated, there's no explanation of benefits available. I'm currently enrolled with blank health plan. My physician blank is paid capitated amount, and I pay blank amount per each visit, and the patient signs and dates it. That way, they're never going to get anything but that $5, $10, whatever it happens to be, copay. A non-participating physician must file an unassigned MSP claim. Patient is directly reimbursed by Medicare. So here, they're going to pay the patient directly. So again, there are benefits to participating so that your patients do not get the checks. If you look up on the top of 403, this is just an example of different Medigap plans. And then you can see here there's A, B, C, D, F, G, K, L, M, and N. And then what they cover for benefits. So some of the Medigap plans cover Part A deductible and Part B deductible. Some will only cover Part B and not A. So again, if somebody is in that situation when they're looking for these types of plans, some things to keep in mind as far as what's covered and what's not covered. The risk plan, beneficiaries receive non-covered services from providers or receive covered services from providers who are contracted in the HMO network. Enrollees are called restricted beneficiaries. There's also what we call cost plan. Beneficiaries receive Medicare covered services from sources in and out of the network, and they are called unrestricted beneficiaries. Again, we mentioned the automobile or liability coverage. Liability is not secondary to Medicare because there's no contractual relationship between the insured and the third-party payer. So if you treat a Medicare patient who's filed a liability claim, you have to bill the liability claim first. Then you can look, if they don't pay within 120 days, then you can bill Medicare, and Medicare will process claims. But there are time restrictions. A lot of times, you may not know it's a liability case and the patients have Medicare. So you bill Medicare, but Medicare in their system has that it's a liability case. And they'll deny the claim, telling you that somebody else should be paying the claim instead of them. So that's kind of a, oh, okay, they've got other coverage of some sort. Non-par physician can file unassigned claim for Medicare secondary payment only if the payment by the liability carrier is less than the limiting charge. If Medicare payments have been made but should not have been because they're excluded under the provisions, then they are subject to recovery or refund. On 404, this is a example of a senior managed care plan or a Medicare replacement plan. So this is Empire Blue Cross Blue Shield out of New York. But this is acting as the patient's Medicare instead. So you can see they have a copay, $50 for a specialist, a prescription deductible of $100, and then a copay for medications. So again, depending on what they are opting for. Now, if they opt to take a managed care plan instead of the Medicare, Medicare makes payments directly to an HMO on a monthly basis for Medicare enrollees who use the HMO option. Enrollees still pay the HMO a monthly premium. So again, they're still paying to have that extra insurance. Now, some of the HMOs provide services not usually covered by Medicare, such as eyeglasses, prescription drugs, routine physical exams. So once they've converted from Medicare to an HMO, they cannot go back to a former physician and expect Medicare to pay their bill. So again, something they have to keep in mind with regards to covered services. If they've switched to a managed care plan and now they want to go back to Medicare, they have to notify the plan in writing of disenrollment, and there is a Medicare Managed Care Disenrollment Form, CMS 566. They have to attach a copy of the letter and that form and present it in person to the Social Security office. They don't send it back to Medicare. Bring it into their local Social Security office. There is an open enrollment in the fall of each year. It can take the plan 30 days for disenrollment and can take Medicare as long as 60 days to re-enroll a patient. So, in between that time, they may have to enroll in a supplemental plan or take their chances should they become ill. I talked about the risk plan. They receive the covered services from the providers who are contracted, and they are called restricted beneficiaries. And then the cost plan, they receive covered services from sources in and out of the network. Carrier dealing prepayment organizations, they may be set up by a medical practice under contract to the government. Patients sign a contract agreeing to a monthly fee, usually $20 to $25. It's supposed to cover all Medicare copays, deductibles, and non-reimbursable expenses. A lot of these plans in the past were run by HMOs, but now practices of 12 to 15 physicians are opting to run their own plans. Again, I am not familiar with any type of these plans in our area. But again, by keeping up to date with the insurances, that helps you know what types of plans are available in your area. Utilization and quality control, QIO, Quality Improvement Organizations. It's called, or was referred to as professional or peer review organization, and they contract with Medicare to review medical necessity, reasonableness, appropriateness, and completeness and adequacy of care for inpatients, outpatients, ER, nursing facilities, ambulatory surgery centers, whatever it happens to be. So what they're doing is if there is an inpatient and the patient's been in the hospital for a month, they're going to review all of that patient's chart and everything they've had done during that month and find out if there's something better that could be done or why the patient is still there a month later. Is something being missed? Has all the testing been ordered that could be ordered? They're wanting to make sure everything is in place. The Federal False Claims Amendment Act. This is another federal law to prevent overuse of services and to pick up on fraud for Medicare. They offer incentives of 15 to 25% of any judgment to informants who report physicians suspected of defrauding the federal government. So, remember what we were talking about earlier about those claims for your son?
Yeah.
So let's say that was Medicare. Not that it would be, but let's say it was a federal program. Mm-hmm. If you reported that to the federal program and they go in and do audits of that company and see that your son really didn't have those services on those dates and they were just fraudulently billing, when they recoup that money for those services that were not performed, if you were the person that brought that to their attention, you get a percentage of what's collected.
Oh.
Another fancy word they call it is whistleblower. Right. So, and it can take time. Nothing may ever come of it. It depends on the situation, but
right.
it does happen.
Huh.
So, it is under that Federal Claims Act. Again, they call it whistleblowers. You report physicians suspected of defrauding the federal government or overcharging, scheduling excessive visits. The Office of the Inspector General, they work closely with the Medicare insurance companies and the FBI, Federal Bureau of Investigation. So again, they are looking for that type of stuff to be brought to their attention, and then they can follow up and go further from there. On page 406, again, you'll see there is a hotline. They listen to the complaint. They follow up on it. Beneficiaries can complain to a compliance person or manager in the office if they suspect something is billed incorrectly. If it doesn't get fixed or they still feel it was billed improperly, then they would in turn go to Medicare, and then they may get something back if it was fraudulently billed. CLIA, 1988, Federal Standards, Quality Control, Safety Measures for freestanding labs, including physician office labs. So if you're in an office and you provide lab work, you would want to be aware of what the CLIA amendments are. You have to have a 10-digit CLIA certificate number that which goes on your claim form in block 23. If you do not have that CLIA number, then and you are providing a lab, you're not going to get paid for them. There are guidelines that you have to do. Payment fundamentals. We talked about participating, non-participating physician, and prior authorization. Again, your participating provider has a contract with Medicare, which means that they agree to accept Medicare's allowable after the patient has a deductible. So yeah, in 2015, the Medicare deductible for Part B was $147. So I don't know what makes me think it's like I want to say 175, something like that is the Part B this year, but I could be a little off. If you are a non-participating provider, you do not have a signed agreement with Medicare, you've opted out of that assignment, you can decline assignment for all services, or you can accept assignment for some services and collect from the patient for other services. If you are non-participating, you receive only 95% of the approved amount, and non-par physicians can decide on a case-by-case basis whether or not to accept assignment. Again, that's up to your practice. A lot of practices either accept assignment or don't. It's much harder to do on a case-by-case basis. Depends on how many Medicare patients you are seeing. So if you look up on page 407, so Dr. A accepts assignment. The charge is $480. They allow $400. They've already met their deductible. So Medicare is going to pay 80% of that $400. So they're going to pay $320. And then the remaining $80 is going to go to the patient. If they are non-participating, the charge was $437. Medicare allows $380. Again, the deductible's already satisfied. Medicare pays 80% of the allowed amount, so they're paying $304. And now the patient has the difference of the 20% and the difference of the limiting charge, because we can bill the patient the difference between what we charge and what Medicare allows if we are non-participating. Patients are liable for that. My gripe with that is Medicare patients, if they're on Medicare, are they going to be able to pay you that in addition to their 20%? They're all retired. So I don't know why providers have to be non-par, but that's okay. And then Dr. C accepts assignment, but the patient hasn't met their deductible. So now they're going to deduct that $147 from that $400 that they allow, and that's going to get added on to the patient amount plus the 20%, and then Medicare pays the 80% of the allowed amount. So again, depending on whether you are participating, non-participating, or not met your deductible. If you're participating, you've got to write off the difference between the charge and the approved amount. If you're non-participating, you have no adjustment. You are getting that difference from your patient. They're paying it. And if you accept assignment and they've not met the deductible, again, you still have that contractual amount that you would be writing off. On page 408, you can see an example of a claim form. In the MA class, we went over the claim form line item by line item. We're not going to go over that completely, but you will see where the dates of service, the CPTs go, the diagnosis codes. 27 is where it's checked off on whether or not they accept Medicare assignment or any insurance assignment for that situation. And that's the big box that we're looking for as to whether or not they are going to send the checks to the physician. On 409, we have prior authorizations. So with Medicare patients who have additional coverage, some of those additional plans may require procedures that require authorizations. Bunionectomies, carotid, endarterectomies, cataract, gallbladder removal, peripheral revascularization, hysterectomy, joint replacements, just to name a few. Those may all require prior authorization. So most carriers have a toll-free line. You can call and get authorization over the line by giving them information over the phone. Most of the carriers also have their individual forms for prior authorization that you can fill out and fax into them with office notes as well. And then when you receive that prior authorization, it would be used on your claim form in box 23. And that shows to the insurance carrier that you did get authorization. They can match it up in their system, and then there's no question that exam or test or surgery was approved, and you shouldn't have any trouble getting it paid. If you look up on 409, it talks about advance beneficiary notice of non-coverage. You should always have the patient sign if you expect Medicare to deny payment. You can look at their local coverage determinations as well as their national coverage determinations, but if something is non-covered by Medicare for a specific diagnosis code, and that's the reason you're going to be doing it for that diagnosis code, you know it's not going to be covered. If you do not have the patient sign an ABN, you are not going to be able to bill the patient for that. When it is denied by Medicare, it is going to end up being a write-off. So your provider eats it, so to speak. Again, with the limitation of liability by Medicare, you need to inform the patient, have them agree to pay for the denied service in advance if that's how you ought to do it. Some will wait until it's submitted and then bill your patient. But again, with Medicare, make sure you have access to those national coverage determination and local coverage determination. The time frame for the screening colonoscopies, for example, is once every 10 years. So if your patient doesn't want to wait 10 years and they want to have it done sooner, you need to have them sign the advance beneficiary notice, because you know Medicare only covers that once every 10 years according to their coverage determination. And if the patient's just a worrywart and has to have it done sooner, and there's no medical reason that fits why Medicare would pay for it sooner, if you do not have the patient sign that ABN, you are going to eat that cost of that colonoscopy. You will not be able to bill your patient. So again, you can determine which services require an ABN by looking at those local coverage determinations or national coverage determinations. And if you look on page 410, here's an example of the advanced beneficiary notice. So in box D, you tell them Medicare, if Medicare doesn't pay for B12 injections, you may have to pay. Medicare doesn't pay for everything. So that's what Medicare does not usually pay for this injection or this many. What is the estimated cost? And then you give the patient the option. I want the B12. I may be asked to pay now, but I do want Medicare billed just in case. If Medicare doesn't pay, I know I'm responsible, or I can appeal to Medicare. Option 2, I want the blank listed above, don't bill Medicare. I will be responsible. And if you don't bill Medicare, they have no appeal rights because they have no claim that's been submitted. Or I don't want the item listed above. I understand my choice. I'm not responsible. I cannot appeal to Medicare to see if they would pay. So you give them that option. If they sign an advance beneficiary notice, when you submit a claim to them, if they say, yes, go ahead and do it, there is a modifier GA that goes on your claim form. And that modifier GA tells Medicare that you have this on file. And that will allow you, if Medicare denies it, to bill your patient. Otherwise, it's a non-covered period, write-off. You'll never see it again. GA. And again, that's on page 411. You can see that. Don't get confused by the issue of non-covered Medicare services, because these may always be billed to the patient. You do not have an ABN when a service is never covered by Medicare. Those patients get a different form. It's called a notice of exclusion. And again, that form is also on Medicare website. But that's something that we know Medicare doesn't cover, period. Then you don't have to have them sign that waiver. But if it's sometimes covered, or that screening colonoscopy with a time frame, that's when we'd have that ABN signed. Elective surgery estimates, a non-participating provider who does not accept assignment for elective surgery, for which the actual charge will be $500 or more, needs to submit in writing the estimated fee for the procedure, the estimated Medicare approved allowance for the procedure, and then the difference in the physician's actual charge. And that became effective October 1st of '87 with the Tax Reform Act. Had to be submitted in writing if they were going to do a elective surgery. You give a copy of the estimation letter to the Medicare patient, and you keep one for the file. You document patient's acknowledgement by having them sign the bottom of that letter. We'll start the Medicare reimbursement. Again, Medicare pays 80% of the approved charge. Payments to hospital for Medicare services are classified according to what we call DRG, or diagnosis-related groups. So when a hospital bills and they are using their diagnosis codes, they are looking at these diagnosis-related groups with regards to their payments. In 1984, the Deficit Reduction Act established a participating physician program that offered incentives to those participating providers and froze the fees of non-participating providers. The Omnibus Budget Reconciliation Act of '87 introduced the maximum allowable formula, which developed the maximum fee or the limiting charge for those non-participating providers. Now, if you look on 412, here's an example of that exclusion form with Medicare. So this is the one where the service is never covered by Medicare. You need this form, not the ABN. Reasonable fees. This is the amount that Medicare participating providers agree to accept. It's listed on your explanation of benefits or the remit advice. And again, when they accept assignment, he or she may bill the patient only 20% of the allowed charge. Interest fees cannot be assessed to Medicare patients. So if that 20% needs to be put on a payment plan, you can't charge your Medicare patient interest. If you look up on the top of 413, here's an example of that worksheet we talked about for the elective surgery, and an example of the letter that would go to the patient and be signed. It is permissible to collect the deductible at the time of service if you know how much of the deductible has already been paid. So you said earlier, could you collect that Medicare deductible up front? Yes, I guess you could, but if you don't know whether the patient has other outstanding claims to Medicare, that deductible may not be going to your claim. It may be going to the primary care, and then you're going to just end up refunding the patient that money, which then costs you a check, maybe postage, whatever it happens to be. State laws require physicians to accept approved amounts for their Medicare patients. Again, if they are participating for being licensed to practice medicine in that state. There are states that have rejected mandatory assignment laws. So some states said all providers have to be participating. But we have Arkansas, Florida, Illinois, Maryland, Montana, and New Hampshire that have rejected that. They said that their physicians have a choice on whether they will be participating or non-participating. So with that, what I'm going to do is I'm going to leave off there with the resource-based relative value scale, and that's where we will pick up next week. There's really not a lot more in here. We're going to go over some EOBs, remit advice, and the time limit, and that kind of stuff. So we'll finish 12 next week. We will do Medicaid, and then we will go on to TRICARE. I think you guys are going to be all set for class next week. I know there's supposed to be another storm next Thursday, so they've already canceled class for tomorrow night because of the storm, but I think you guys should be all set. But if there is a storm that comes up on your class night, you will either hear from Jamie or Amy, whoever happens to be at the school. Most of the time, they'll send out that notice for me because I'm at work and can't always do it as quickly as they can. But hopefully that won't happen. Any questions?
I'm okay.
Good to go?
Good to go.
All right. So, contact Jamie and Amy and have them do those overrides on that exam for you.
yeah. Okay.
All right. And other than that, I will see you all next week.
Thank you.
You are welcome. Stay in tomorrow with a storm.